could start, let me just make one announcement, which is I opened the Moodle. It was my mistake that it not open. What you can find there is the recordings of the previous two lectures. However, at least through yesterday's recording, which I checked, it turned out that there was some kind of static that induced noise for about a third of this, something like from between the middle of the lecture to the, I don't know, a little bit before the end, the static noise, but then it comes back. I simply wasn't there, the technician said it. We fixed it today, everything is working. So with the exception of that piece, I don't know how big it is, maybe half an hour, but I'm not even sure. With the exception of that piece, everything is recorded there, all the classes, and hopefully today's class, hopefully the problem is solved, and today's class will be there. In addition, I also put there the Broca's region book that was published about 15 years ago, which gives you multiple perspectives on Broca's region. The reason I put it there is because in the end, and I noted the page number, there is a collection of historical papers like the 1909, one of the 1909 papers by Corbinian Brodmann. All of you have heard about Brodmann, you might read something that he wrote. The original paper by Paul Broca, the paper from Norman Geschwind, which you could access via my website as well, and some other historical papers which you might be interested in. If there's anything else that we feel is important, we'll put it on, and we'll see whether these guys will agree to put their presentations on. If it's up to them, and then I'll put everything on. I don't want to put you on the spot, so it's on, right?
The noise is because I switched it off because I went to the bathroom.
Don't apologize. Don't apologize. You know, I once heard about a rabbi. You know the story of the rabbi in Stockholm? So there was the chief rabbi of the Stockholm synagogue in the middle of the holiest day of the year, which is called Yom Kippur. He had like a microphone of some sort because he was giving a sermon, and he went to the bathroom during the break from the prayer. From the bathroom, he called his mistress. And he forgot to switch it off, and the whole synagogue heard it. Okay? This was like 15 or 20 years ago. I heard it from the son of his replacement. Yes. Okay, so switch it off when you go to the bathroom.
Yeah, I didn't switch it.
And I was not implying.
Okay, so yesterday we didn't finish the last bit of the planned talk, so we have to do it today. Originally, this day is dedicated to wake surgery, but we have to do some principles of CNS monitoring and mapping, otherwise you will not be able to understand why we're doing the test and how we do the test from a technical point. Okay, there's a difference between mapping and monitoring. There's a difference, and the difference is subsumized under the title Intraoperative Neurophysiological Monitoring. So we have monitoring. Monitoring is just observing the functionality of the functions of the central nervous system, and it is passive. It is basically just looking whether the motor and sensory functions are working. Whereas the mapping is active, localizing functionality. Big difference. And up to, let's say, the 20 years ago, there was only the mapping, the monitoring available in neurosurgery. On a large scale. And now we have this mapping techniques available, and this is really a game changer, as you will see. So, for the monitoring of the CNS functions, we have the monitoring of the somatosensory system. So now the somatosensory system, like most of you know, is a system which carries information from the skin through a complicated pathway, finally to our consciousness on the cortical surface of the brain, the so-called S1 somatosensory cortex. And on this travel from stimuli that we can apply, we can detect this volley of electricity on several points. Most importantly, of course, the endpoint of the cortical surface. And this is basically the pathway that the electrical volley travels through. And as you have seen in this picture here, we can detect this volley with different different points and see if it's going through. For example, we could basically, if we do spinal cord surgery, detect the volley coming up to this point, but never up to the head, so we know that there's a problem. And then we have information that the somatosensory system is kaput. Okay, and there's a certain topography towards this on the cortical surface as well. But in principle, we are just working with the upper and the lower limb. So we apply electric current in the tibial nerve foot, on the median nerve hand, and then we detect it through an array of electrodes on the skull. And importantly, it is what the curves that we are detecting are dependent on the angle between the electrode which is detecting it in the bipolar. So two electrodes are looking at the volley of the electricity, and it is dependent on the position of the electrodes and of course on the position of the volley where the electricity goes through, and that is indirectly dependent on the position of the brain. And this makes this method very vulnerable towards changes of the position of the brain, and that's exactly what we're doing when we do brain tumor surgery. So this is already a very severe technical limitation that you need to know when you see, for example, the video that we're showing tomorrow. That's what we usually see. This is a volley of electricity coming up. At 20 microseconds, we see typically this signal for the median nerve. And for the tibial nerve, we see it a little later, after 40 microseconds, because the electricity has to travel a long way, more like, okay? That's the electrodes that we need to detect the volley, always towards a reference. And that's what the volleys, the signals look like when we apply a median or tibial nerve stimulus. As you can imagine, there's a lot of electricity in the brain going on, and the only way to detect it is that we average. The moment that we give the application of the current in the tibial or median nerve, the machine knows that you have to look for the signal, and it does it 200, 400 times, and the machine averages out the electricity which is expected at that time. And then you get these curves. This is really important because when we work on the brain, when we work on the vessels, we have a very close correlation between changing of this electricity, these curves, and ischemia. As long as the brain is perfused, everything is okay. But if we compromise the vessel, which is supplying the somatosensory cortex, we will have a drop of these curves within a couple of seconds. So we can use this system as warning sign. But you see, as I already said, this is very dangerous because we work, and then everything's fine, and suddenly some guys who are sitting in front of the monitor say, oh, sorry, something wrong. We always can stop there, put in the brakes, and hope for the best, but this is, of course, not the way you want to do surgery.
Wait, I just want to understand this point. So first of all, this is intraoperative monitoring that you're talking about. And did I understand you correctly when that you said that sometimes there is some change in cerebral blood flow that you don't see, but the machine detects?
Yeah.
There are such things, actually.
Yeah, like here. You see, this is normal. When we have to clamp a vessel, things are changing. You see that the amplitude and the latency of the curves change, the morphology of the change. We don't go too much in detail, you just need to understand the principle. It changes, you get the warning, let go, get out of the situs, wait, irrigate with water, and hope for the best. And in fact, here it's coming back. But that is not always guaranteed. Sometimes the damage is done. This is completely different from mapping, which I will explain later on. So the motor system is also monitored by the so-called motor-evoked potentials by applying the current on the cortical surface very near to the motor cortex. And then we have the volume of electricity not going in but going out. At the end, we have the depolarization in the muscle, which can be detected by a needle in the muscle. This is called motor-evoked potentials, and it can be applied from the motor cortex here, and the SSCPs can be detected from this area. Now, the way monopolar stimulation of the MEP functions is that we basically take the stimulator, put it on the cortical surface, apply the current, and we depolarize the neurons and therefore induce depolarization and the wall of electricity going down. It is done with a current which is called train of 5. We give 5 applications of the current. And it's always done with a monopolar stimulator, which is building up current between the tip of this one and the reference electrode. So you see that we remember that the first row of electrodes was a little interior here, and the second one is directly above the cortical motor cortex. We apply current here, then we have this depolarization. We do this transcranial, this is in the skin, or we can do this directly on the cortical surface with the so-called grid electrode. This is basically the point that I showed you that infuses electrodes into the brain. And then we can have a very nice result in stimulating in this very strange area here, directly motor cortical areas to get a result. So this helps us to identify the fact that motor functions are normal. We can stimulate on the cortex and we get a jerking of the muscle, so motor system is fine. And for this, it's the same thing like for SSCPs. We stimulate, and sometimes something happens. Early warning sign, we stop, hope that the patient recuperates, and that we see again the motor system. This is the end point where we have electrodes in the muscle and detect electricity induced by stimulation on the cortex. Okay, this is just to let you know that we have this system in place to be very sure. But the more important technique is the mapping technique. The mapping technique can be done in the asleep or in the awake situation. Now, the important point is that we have an active identification of functionality by the surgeon. Again, with the straight of 5 method, I showed you that. And here, this is important, shows you that though it looks like a very precise method, just putting a rod on the cortical surface, it creates a huge field of electricity. And this huge field of electricity can have anywhere the depolarization of the neurons and therefore induction of the motor functions. So we are not really precise in doing this. And with this method, we can only stimulate motor functions. This is only for motor functions. It's not for language, it's not for visual things, it's just for motor functions. You see how the current is traveling through the brain. What we usually do, and you will see this in the videos, is that we map the brain surface for functionality. We put it on the surface, turn on the amplitude, we turn on the current, and then we see if we have muscle responses. And the lower we get with the amplitude, this current that we need, and still have a motor response, the more likely is it that we are stimulating the primary motor cortex. And then, when we have that, we can go to the cortex which is harboring the tumor, test again, and if we don't get a motor response, then we can be quite sure that this is not correlated with motor functions. So in motor-wise, we can do a resection. And then we go into the brain and we go into the subcortical areas. At a certain time point, we will be still quite sure that we can resect. at a certain point, our physician will say, oh, I think there is something coming up, but I'm not sure. This is the area where we are in doubt. And then, of course, he will say, oh, I got something. And then we have to stop. And this point here, this yellow arrow, makes our situation so complicated because we need to resect this malignant brain tumor, and on the other hand, we cannot really be sure it's already functional or not. So this is not digital, it's not 1-0, it is maybe. Okay, but this technique limited to motor functions. The second, much more interesting technique is the so-called bipolar stimulation. Now we don't have not one rod, but two, and the current is applied between those two rods. So it's much more localized when we apply this on the cortical surface. And for the properties of this technique, we don't induce a motor response by depolarization of the neurons. We block the functions. So we can give the patient a task. So this is correlated with the wake surgery. We put it on the brain surface, we turn on the current, and the patient stops doing what he's asked to do, and he stops moving his hands. So we are not looking at motor functions just detected by two needles in one muscle, but we are looking at the whole thing. Much more information about the functionality of the hand, of course. We can make very simple psychological or cognitive tests by asking the patient to point out the big red one or the yellow quadrant or whatever. We can work with visual fields. The patient is supposed to look at the point here, and then he has to name all the things around it, so we know that this visual fields is intact. And of course we can do, and that is the big point here, we can do extensive language testing. And what we find when we do the cortical mapping with this technique, and you need to know that every number that you see here is correlated with functionality. So we have, for example, speech rest here, you can have the hand movement there. You can have several scenarios after the mapping. You can have this completely, this functionality covered tumor. So this is not resectable if you want to accept a very severe deficit for the patient. You can have a partial functionality within the tumor, or we can have free field without any functionality necessity. And this is already starting off the decision-making process, functional or not functional. So this is all summarized in this paper. That was the techniques that we wanted to give you yesterday, and now we proceed with the program that we have for today. Okay? This was 10 minutes less through electrophysiology. Normally, a medical student takes half a year for it. So you should have some questions. Please.
Usually, are all of the techniques invasive? So you have to open up and then put the electrode inside.
Yeah, we put the electrode on the surface of the brain. It's
So you have to open the skull too.
Sorry?
You have to open the skull to put.
Yeah, for the monitoring techniques, that's not needed. It's not necessary in our case because we can do transcranial on the cortical skin surface. But for the stimulations technique that I showed you with the mapping, we always need to expose the brain. And not only the surface of the brain, but also the key parts of the brain.
Because you do this kind of ear operation monitoring about functionality, I would just have a question generally, like because the brain tumor is supposed not be involved in the regular functionality, supposed to. I'm just curious, like if you just found it actually was part of the functionality pathway for the patient, for the people to behave after they get the brain tumor. For example, if it was part of this motor pathway from brain to spine, if you cut it like a slight piece and all this functionality just goes away because it's already involved in the normal functionality.
It's basically exactly the point of the mapping techniques, that the tumor might have already distorted the function or is still functional. So we need to decide that. But you have to, when we showed you yesterday, when we showed the biology of the tumor, you saw that the tumor is infiltrating surrounding tissue. And where you have some tumor cells and functionality. This method helps us to understand whether the functional deficit, whether we will have a functional deficit or not. And yes, the tumors can be highly functional. So, as we have seen in the last 2 slides ago, the tumor might be completely functional. So, did I understand your question?
But it is weird because it's not neurons, it is glial cell. Like, why is functional? It's not neurons.
Yeah, but first of all, we need to see that on the cortical surface we have glial cells surrounding functional neurons, and they consist of, this is a tumor. And in the depth of the brain, we have the axons coming from the neurons, which are involved in the tumor. So or we cut the program, neurons, surrounded by brain tumor cells, or we cut the cable, infiltrated by brain tumor cells. That's the danger of the surgery. These techniques should inform us about the functionality.
So I can tell you, just let me say one thing. I can tell you that if you look at people who had stroke, and you look at the lesion, you start looking at the details of lesions, you see two kinds of things which resemble this type of puzzle. One, occasionally you see that inside, if you have a very good high-resolution MRI, you sometimes notice that inside the lesion, so it has a volume, inside there's live tissue. And there's no way for you to rule out the possibility that this tissue is functioning. It may very well be functioning, even though you don't quite detect the connections between it to the rest of the brain. Secondly, if you try, which we occasionally do when we want to map such lesions, you try to get exactly the contour of the lesion. If it's a stroke, sometimes you have a chance and it's very clearly delineated. You notice that there's a little layer just around it, which is known as penumbra. And you look at that, and you never really know if this penumbra is functional or not. So there's a lot of puzzles, and this is just via imaging. You don't look at it directly. But there are lots of puzzles about what part exactly is damaged and has functional consequences. It's not easily solved.
That's it.
Yeah, you said that the bipolar stimulation is much more specific and that you can test many more things for the mapping. Sorry. You said the bipolar is much more specific and that you can test many more things. So why would you use the unipolar stimulation? In what situation would that be helpful?
Very good question. The answer is that for monopolar stimulation, you don't need the patient awake. And if you have doubts about the compliance of the patient, you might consider to do it asleep if your concerns about functionality is limited to motor functions. It's more localized, and that means also that you apply much more current in the same spot. And that is quite often we do single epileptic seizure. So we can have a seizure in a surgery, which is something that has been feared very much by many sources. But if you prepare yourself and prepare the team for that, then it's not a
Okay, so now I start with the program for today with the third day with a little repetition. So if there are any questions, hopefully we'll help you, and then you can, of course, just raise your questions.
I don't know how useful it will be, but...
So again, why awake? You all know now glioma, tumors from the nerve system are infiltrating cells. And you all know now as well that we want to resect as aggressive as possible. Minimum is the visual MRI tumor tissue, but we also want to go beyond that limitation. And what we just discussed, in tumor cells, in high-grade glioma cells, and even more in low-grade glioma cells, we expect tumor cells right next to functioning, maybe eloquent cells. So we need to differentiate between what is functioning what is not be possible to be removed and what can be examined. And you already saw this picture. Here you got a picture from the cortex with all those numbers identifying eloquent tissue, and the surgeon is looking for a way to the tumor. And here in the picture you can see it's quite, well, not possible actually, because it's all over eloquent tissue, and the risk in this kind of tumor, in this kind of surgery, the risk to produce a permanent neurological deficit may be too high. So that's the reason for AWAKE. We want to have a secure possibility to identify eloquent tumor tissue. And you already got to know the technical details. So we got two options that we got asleep or awake. And even if we do an awake surgery, it's depending on the hospital. So in our hospital, we're doing it first, the patient is asleep, then we wake him up when we need the patient to be tested, and afterwards we get the patient is asleep again, but it's not intubated, just got some medication for sleeping. But you can also do it awake. So there are also clinics where the patient is not sleeping at all, and when you're doing stuff like the craniotomy, which is really loud for the patient, imagine getting a burr hole when you're awake, the team is sitting right next to the patient, explaining the situation, and maybe telling a story. For example, the helicopter is coming, the boat is running, that's why the noise is coming from, and it's working as well. This, when we're doing the operation, of course, there are things, the positioning where the patient can have pain. The brain tumor, the brain tissue itself, it's not painful for the patient, but of course, there are nerves on the skin. You have seen the picture that we need to fixate the head, so the patient cannot move the head, and all these points. We get a local, you can see on the picture, we got a local anesthesia for the nerve, so there won't be any pain. So local anesthesia for the clamped skin incision and for the clamp. So the patient will feel not pain, will feel that the head is fixated, but it won't hurt anymore. Okay, you can see it quite better than we do skin infiltration, right where we fixate the head. Basically, the technology is quite simple, and the simulator you were just introduced to, the bipolar simulator. This is a picture of the old Ogeman stimulator, which is how old is it? Actually, I don't know really.
Sorry? Ogeman is like 97.
Yeah, but this machine, we haven't got it anymore, but it was.
It's still in my office because I think it will become very, very expensive sometimes. This material value of this machine is something around 10 euros or something like that. It's very, very simple. It's just a bipolar stimulator, nothing else.
So this is stimulator, bipolar stimulator, where you can do the awake testing. Again, the technique, so bipolar stimulation. Here you can see it again. So the electrode goes between those two branches, and this is localized functional stop. So we try to block function with this technique. And this is how we do it. We're not starting, of course, with a very high electricity. So we start with a lower electricity and then go up till we get the point where the eloquent structures are, and of course that I know how much ampere, how much electricity do I need to stop the function. And it can differentiate from patient to patient.
Let me ask you a question, because there's a kind of a similar dilemma in functional MRI. And it goes like this. the way you do it, you first test on motor cortex. This is how you determine the level of the Ampere level that you introduce. But how do you know that it's uniform across the brain? It's the same kind of dilemma. People fit the hemodynamic response function, assuming that it's pretty much uniform across the brain, but maybe it's not.
It's definitely not uniform.
So
that's why we tested. So that's why we were doing a bigger craniotomy.
I'm talking across the same brain, not between individuals. Once you fix it on the motor cortex, and then you go, I don't know, to visual cortex or to language, how do you know that that part of the brain requires the same level of stimulation? I mean, what does your experience then?
Well, to be honest, we assume that, right? So
the idea behind that is that we think that the motor cortex is the most sensitive system in the brain for motor stimulation, because everything is there. We directly are on the neurons, and we depolarize, and we induce, and we stop. That gives us a threshold, an idea about the threshold. If it does not work on the motor cortex, then it will not work in compromised tumor cells, functional errors, no potential functional errors.
So people have actually done studies like this, moving from one area to the next and showing that you get blockade with different, the upper threshold is the...
With a bipolar stimulator, we get only the stimulation effect directly on the motor cortex, directly on the structure. It's very, very... You can have a bipolar stimulation effect if you go with a very high current at a certain distance. For the bipolar, I think this works, that we say if you have a threshold on the cortical surface, then you're quite sure that if you apply it in the lower part of the brain or different part of the brain, you don't get a response at all. As a monopolar stimulation, since it's such a large field, we cannot be quite sure. We could, sure it's not the same. There's a story by Stiran demonstrating that the distance of the monopolar stimulator towards the cortical spinal tract is approximately 1 millimeter to 1 milliamp. So if you have 10 milliamps to get a response, you probably, that is not true. We have seen that it's not.
And again, that picture showing how it works. So we start on the cortical level, looking for the eloquent region, looking for our milliampere, so how much electricity do we need, and then we go subcortical, checking where's the eloquence, can I resect yes or no, with different kind of tests. So I also have to have the anatomy in mind, but we will come to this later. So, of course, hand movement. But this is just a picture showing how we map it. So we're going on different places with the same electricity, and here we got the stop, the change in the hand movement. Again, that picture showing you the different possibilities you've got. From the first picture where you can see this is not resectable. There's a very high chance that you risk a neurological deficit. In the other two ways, it is possible because you can find, by mapping, you can find a way to the tumor. So,
11, 12, 13, 14, 15, 20.
This patient is a native speaker of German.
1,
Mm-hmm.
2.
you will.
From Eastern part of Germany. So not native.
Tomorrow you will see the whole movie of this. Friday, Thursday? The day after tomorrow, you will see the tumor where it's located. We will plan this surgery and you will see the complete movie. But right here you saw that we were stimulating the cortex, and she just, even if you don't know German, she was counting 1, 2, and then she stopped. So we know exactly which position is the M1, because we're just testing motor. We're not testing language, just a motor function.
Speech.
Well, yeah, speech, but as well we can test, or what we try to do is to combine it. So the patient is counting and moving the hands. So 1, 2, so we got different motor systems we can test at the same time. Any questions so far? Please don't hesitate to ask. Okay, there are 2 possibilities to resect. It's kind of a philosophy. So we're doing quite large craniotomies because of that reason, that we know exactly where's the M1, where the motor cortex, and how much electricity do I need to stop a function. There's another possibility, not with a huge craniotomy, but with very small craniotomy. But then you have to rely on a negative testing. So then you test and you just have to rely on that nothing happens, but you're not really sure how much electricity do I need, how far am I away from the eloquent regions. So this is an extra point giving us a more secure situation for the patient as well.
I just want to point out that this concept of eloquent region is really depends on the function that you're trying to test.
And you will see it in the movie as well, that you have to think about where am I and which function do I expect. For example, motor function, we can move the hand, sure. Counting, that's easy, quite easy. But if I refer to a language function, for example, speech arrest. So we're stimulating, you will see it, that the patient is saying, this is, but couldn't say the word. When I resect in that region, and counting would be possible. So I would resect and I wouldn't know that I'm interfering with the fibers already. So I have to adapt my testing for the localization of the tumor where I resect. It's very important.
I'm simply, I just, maybe this is not the right point to say it, but one of the first times that I was at the operating room with the 2 of you, Michael was showing me the left temporal pole of the patient. Mm-hmm. And he said, we have it on video somewhere, and he said something like, it's a silent region, it's never active. And I said, just let me be very clear. Are you telling me that the left temporal pole is a silent region? Because the whole world of neurolinguistics believes, not myself, but the whole world that studies single word semantics will tell you that this is where single word semantics is, based on MEG data, based on functional MRI data, I think even based on MEG data. Actually, MEG data is MEG data. So I'm completely puzzled about this, and you said, yes, it's very clear, any neurosurgeon that you will ever meet will tell you that the left temporal pole is a silent region.
It's silent for a neurosurgeon.
You witnessed the resection of the left temporal pole. The patient was, in our terms, after the surgery, completely normal and was discharged a couple of days later. But this is again the discussion: did I really was I able to detect the deficits that you, as a linguist, would detect when you talk to the patient? We discharge the patient. We show you tomorrow a picture of a neurosurgical outcome score. The patient is good because he's walking and talking. That's of course not a good result in itself. If you look more differentially, and that's exactly the point that you made. We didn't check the patient for single word semantics.
Do you only do tests for interactions and language, or you also do tests for memory or emotions?
We can test for memory. Testing for emotion is something that we will show later on when we have the time today. It's very difficult, but mostly we test for language, we test for motor functions, sensory functions, and visual fields.
So memory you do?
We can do memory, this working memory, give them large numbers, six digits, and we try to repeat them as we do them. And then we can see some interferences, but it This is very easy. If you in one is rest, every millimeter of this area is correlated with motor function. So we will almost never interfere with motor functions. Yeah? But with working memory, memory, it's very hard to say where the localization of working memory is located in the brain. It's diffuse localization. This is really simple.
Honestly, what we're seeing is that there's a huge cultural difference between the neurosurgical and neurological culture on the one hand, and the scientific culture in a sense, because people look at completely different things. I'm not saying that you're looking at the wrong things, but it's just it's a cultural difference of a very interesting sort.
And silent for a neurosurgeon means we cannot test that regions, and that's it. And if you think about the testing, you've got this bipolar stimulation, you're putting electricity on the brain, and it's for 3-4 seconds, and then you need to have a reaction. So it's very easy with counting, hand movement. It becomes more difficult with language, much more difficult. Emotions, very difficult. Memory, how do you test it? So we can say, repeat 3-4 numbers. We stimulate and we say, okay, remember 5, 0, 2, 1. And ask the patient 3 minutes later, what about the numbers? But it's getting more and more complicated. So we're missing the perfect test.
It's clear that you cannot have a huge battery because time limit. It's very, very clear. There's no question about it. But it's just like an inherent limitation of this technique.
I mean, this, if you may.
Sure.
This part of the talks, this part of the lectures is to show you the engineering part of brain tumor surgery. So if you come up with tests asking me to test the functionality of the left temporal lobe tip, then I would say, okay, I can test that with bipolar stimulation, but since I need to have this positive control, I need to expose, for giving you the test here, for performing the test here, I need to expose the motor cortex. So if I do this, then you put the patient in a situation that I expose large parts of the brain because otherwise technically it's not possible to get this positive control. And therefore I will have a craniotomy like this instead of just making very small flap, minimal invasive. And this is, of course, if you do this kind of testing, it's never minimal invasive. It is very huge surgery. Of course, just doing a skin incision and removing the big bone flap does not make the patient it's not correlated with complications per se, but of course the number of complications will decrease, and of course we expose much more brain.
Okay, again the point for the positive testing. What do you have to think about? Willst du, soll ich weitermachen oder willst du nachher machen?
Wake surgery is not of course you can imagine that brain wake surgery has more complications, question mark, not really has, but it has a certain perspective. The first thing is that we have a time limit. If you wake up the patient, we do gets normal anesthesia, then we remove the ventilation tube, and he wakes up, and then we usually have 1 hour, 1.5 hour when the patient is alert, and then he gets really tired and he can't go on. So we have all the important things that we need to do with the patient are restricted to 1.5 hour maximum.
And he's in our hands. There are some neurosurgeons
who claim that they can go on for 5 or 6 hours, but then we get tired. So there's a time limit. Then you must imagine that the patient is without anesthesia, so he has not a controlled ventilation, and therefore it could be that he is hypoventilating, and that means that the brain can swell. And this is a case where we had the brain swelling. I don't have the video for time scaling, but you see that the brain is coming out, and this vein here is blocked. And if the vein is blocked, the blood cannot get out of the brain. the arterial pressure puts even more blood in, and we have very severe stuff. And there are countermeasures against that. We need to know this, but this is not. I think it's not the case here. But we can do something against it. Then we can have seizures. You see that the patient is stimulated with bipolar stimulation, and what is happening now? You see that the muscles are starting to jerk, and the EEG shows a typical pattern of a grand mal seizure. And you see that we counter. You see that the whole thing is shaking. Yeah? And what we put on is ice cold water, and with the ice cold water, it's typical spikes and waves on EEG of an epileptic seizure. And we cool down the brain, so we cool down the metabolism, and then before we get control of the situation. And occasionally things like this happen. Clamp opens, and the patient falls out. And that's where you have to become very kind, very quiet, very concentrated, and think about what to do. Fortunately, the patient was smiling, everything was fine because we were talking to the patient and hearing the loud voice. Really sure. But something like this can happen because the patient can move, and then sometimes it happens. And it is not true that what we always tell the patient that this surgery is completely painless. It is not. At certain points, especially when we expose the vessels, like working in a temporal lobe tumor on the basis of the temporal lobe, we can have quite severe pain. So we have to ask the patient to tell us immediately if he feels pain, so we can stop it. But normally, in large parts of the surgery, it's completely painless. And when we do this kind of surgery, we do surgery into the infiltration zone. And a big complication, of course, of the surgery is that we have a permanent deficit, which the patient is informed about. So he goes into surgery well aware that he has 6%, 8%, 10% chance to wake up without language or without movement on the opposite side of the body. So he's very afraid about that. But if we do the surgery right, we go into the infiltration zone and we numb the brain because we manipulate the brain, and that seizes the function of the brain temporarily, and the patient must be prepared for that. Otherwise, he will go through a very big crisis after this kind of surgery. Like in this case, where we operated in the central region, subcortically, on a tumor, and we told the patient, you will wake up and you will have a 60% chance that you will not move your left side. But when we tell you that our monitoring told us that MEPs are working, SSCPs are working, then you will certainly recover. You woke up, you had this problem. He's completely relaxed. And this was, you could tell, okay, everything is going through, so MEPs is okay, you will recover.
Wollen wir drüber stehen? Halten wir die Arme nach vorne, Handflächen zur Decke, Augen mal zumachen und auf der Stelle laufen. Vielen Dank. Geht's Ihnen gut? Ja. Irgendwelche Schmerzen, Beschwerden?
Okay. So, we will cover it. So, what are the limitations of bipolar mapping of awake surgery? There's a very famous French surgeon who's doing only awake cases, only awake, everything, every location, always awake. And he says there's basically no limitations. Let's say in real life there are lots of limitations. There are time restrictions, already told you that. Imagine that we plan the surgery, we make a risk assessment for a complicated language-related tumor, and the patient doesn't wake up. So we are completely dependent on the patient's performance. We have a rather high risk of seizures, and we don't have a secure airway. So the patient is not on the ventilator. If he goes into a grand mal seizure, we are in a problematic situation. And we are depending on the threshold. So if we say everything, we test this 1.5 milliamps, and we put this on the brain, and if the patient does not respond, this is resectable. we need to be sure that 1.5 milliamps is really the current that we need. And the problem is that if the brain cools down, we need 2.5 or even 3 milliamps to get the response. We are not aware of that. We think that 1.5 is okay. We resect the tissue and we induce damage. So this is already a very severe technical limitation which makes it necessary that we have positive control. Now, I think that we have given you some engineering information about awake surgery and how it works, what are the limitations or the chances, how it works. Now we would basically come to the more intellectual part of the thing. What do we test? And what is do we really test what we want to test? And I think that Josef should take over. Will you go to the test?
Well, we can just show you the normal testing in 5 minutes. If it's not works, then we can.
So that's the technical background of electricity. Now, we think what is in our hands feasible in testing, and then Josef will give you his presentation.
Okay, so just quite short, we just showed you that we got cortical and subcortical eloquent stimulation points where we can do different kinds of tests. You already saw those pictures. These are important fibers, important ways for language and for the ventral and for the dorsal language system as far as we know as neurosurgeons. And why do we point these fibers out? Because next to the cortical points, eloquent points, these are the fibers that we think we can test. So these are important for us. And again, it's not only subcortical and not only cortical, it's a complete system where we have to test both in both areas. So just quite shortly, what can we test? So what about language? Language is it's complicated. I have to see something, I have to remember the name, I have to speak it out. So maybe the whole brain is reduced, or we need the whole brain for language. And there are different kind of fibers, but we're limited from our point of view for the testing. From the technical point, so we need a perfect test that we stimulate and we induce something, and this something has to be the same. For example, if we test the same region and the patient stops, and in the next test the patient is not stopping anymore, and afterwards the patient says another name, another word, we're not sure what we're testing, and if it's the same. It's quite easy for motor speech, but it's getting more and more difficult for the fibers. So we're looking for, well, in our hands, the perfect or good test. And if you see, in most regions, we think we can test with picture naming. So picture naming is where we show a picture to the patient, and the patient has to say the whole sentence. This is, and then the name. So we try to get a more complex side or point of view from language, but of course it's not. So we as a neurosurgeon, we definitely have to know that the perfect test is not existing. We don't have a perfect test. So what are we using? So sorry for skipping that. We will, I think, talk about that tomorrow again. So we're just coming short overview over the test we have. So we already said we got counting, picture naming. Picture naming, this is a soccer player, and if the patient is really awake and really well doing, we can combine it. So what is the soccer player doing? He is playing, so we try to combine it with verbs as well and with adjectives as well. The pyramid palm tree test is a test where we also not only testing language, but also the association. So this is a pyramid, and the patient has to decide which tree is fitting to the pyramid. And this is again also a test we can combine. So point at the pyramid, point at the palm tree, point at the tree. Face recognition. Of course, we have to think about the cultural background. So I'm not sure if everybody of you is knowing this guy, but I think this one here is quite famous in this country. So you have to think about why is the patient not recognizing this face? Michael already showed you that test, so it's picture naming, but for the visual test, the patient has to look at the point and tell all 4 visual fields. The Struck test, also again, we try to test higher cognitive possibilities. So it's red, green, purple, but the patient has to say here it's green and not purple. This is brownish. This is blue. So the patient has to think about what to say. Reading, memory test, moving. So subcortical motor testing, we induced a stop, and the movement was stopped for quite a while. And now she recovers, and we can go on for the testing. Okay. Soll ich skippen? Haben die morgen Zeichenfilme?
Aha. Das ist ein Roller. Das ist ein Stopp.
So she could say this is, but she couldn't say the word. So if that's the point from right away. If you test motor function, we wouldn't detect that she's got an anomia because she could say this is, but she couldn't say the word. So you have to think about the localization, where I test, and which kind of function do I think there is, which can I test. So, everything under control? No, of course not. As I already told you, the perfect test is not existing. And there are a lot of functions we still don't know how to test intraoperatively. And of course, the big problem is neurocognitive testing, because it's still, it requires too much time. It's not possible during awake situation, and it's not a reliable testing in an awake situation. And the brain, it's just too complex. For example, as you're building here. Another point, we discussing preoperatively with the patient, and we will talk about that tomorrow as well. What is the risk for the patient? And what is the gain of the operation? So survival against quality of life, maybe in some situations. And well, we as a neurosurgeon, maybe we think, okay, talking is fine, walking is fine, so the patient is good. But maybe this is just a too easy look at the patient. So bad could be cannot talk or cannot walk, good, okay, can do both. So that would be a good result for us as a neurosurgeon, but maybe not for the patient himself. So this is one of the future stuff we have to solve, neurocognitive intraoperative testing. I already showed you a few slides of the stroke test, so we try to do a more complicated testing, but still we're looking for a good test for doing easy intraoperative neurocognitive testing. And if you look at the papers coming out and looking for this test and telling us what other clinics are doing, it's limited, and some clinics are doing now the reading the mind and the eye test. Have you ever heard of it, reading the eye and the mind? I think now a picture is coming. Has somebody heard of it, reading the eye and the mind test? Okay. So you see just eyes, and you're supposed to say, what are the eyes telling me? You can do the test online. It's quite interesting. Actually, it's not a it's just a test of one kind of neurocognition. It's a test for autistic people. So it's just one little glimpse of neurocognition. And also, it's very difficult. So I did the test, and I'm highly an autist, so maybe that's why I couldn't do it. But during the operation, again, the situation, you've got the bipolar stimulation, you're putting electricity on the brain, and in that situation, the patient has to decide, what are the eyes telling me? So it's very, very difficult. Another point we're trying to do, Dufour, he's one of the first neurosurgeons really examining it, is a combination. So what he's doing right now is that he's trying to stress the patient out by changing the test after every slide. So it's really stressful for the patient. He has to move, then he has to talk, then he has to do the stroke test, then the palm tree, then this test, and now back to movement. And with this stress, he tries to test the neurocognition. But I think next future, or the new solution, will be maybe your test.
All right, so let's do it. You just disconnect this and I'll connect. Wait, let's turn this off for a minute. Okay. Oh. Okay. This is fancy. Let's see. Let's see how it works.
The best way to go to the cancer.
Allow.
To the tumor.
Yeah, I don't have.
You can't make it.
I can do it from here,
Yeah.
right? Yeah.
But I think you have to
Without this one, right?
Like a program or something that gives you the best
Okay.
solution
The trajectory to the tumor depends on functionality and, of course, practicability. So, for example, if I would go from the right frontal
That's okay.
lobe,
It will go up once I go into this mode.
Oh, okay.
Far away. So what I could give the computer, or what I could think about, is to find the potential functionality on the cortical surface, the subcortical fiber tracts, and the localization of the tumor. And give this to a computer, and the computer would say, okay, this trajectory, that's your question. The best computer for that is me. So we already think about that. Because eventually a program like that will come up, but at the moment it's not on the way, because all the information are so individualized that I would imagine that it would be very hard to train a machine.
Okay, so I'll tell you what we're trying to do together. It's clear that there are tons of limitations, technological, individual variability, the fact that you're dealing with a whole person and not just with a small piece of tissue, tons of things. The one thing that we can try, and I'm not sure that it's going to ever work, is at least to try to introduce evidence-based testing, you might call it, okay? Because the way I see it, and this is the cultural gap here in many respects, the way I see it, I'll give you the paper, you don't need to take pictures.
I want to take a picture of you, not the paper.
Oh, I see. I can give you myself. Anyway, so the way I see it is that there are cognitive psychologists who move around trying to sell their tests, not sell in the commercial sense, but recommend their tests by the fact that they're easy to use, easy to understand, quick and dirty. And many of the tests that you use in neurosurgery have this property. For instance, there's a thing that's called Stroop test. It's about 100 years old. 100, I think Stroop was functioned in 1930, so 90 years old. And I don't quite know what it tests, okay? And there are other tests like line bisection and things of that type that have been kind of passed through the generations of neuropsychologists, and you never quite know what exactly they're supposed to test. But they're quick and dirty, that's clear. And in fact, when you look at work that is currently done in neurolinguistics, so this is work that comes out of Evelina Fedorenko's lab at MIT. She's been trying to develop what she calls a test for language. And the major selling point that she's been using is that it takes you 10 minutes to scope a particular area in the brain. It takes you 10 minutes of scanning. That's very short. This is inspired by her mentor. Her mentor is somebody whose name some of you may have heard, Nancy Canwisher, who has done work on face recognition. And Nancy's not quite claim to fame, but one of the things she's done, she has developed a set of tests that can help you scope out what's called the fusiform face area, what she calls the fusiform face area, after testing for 7 minutes. That's very efficient and it's very good. And the question you might ask is what exactly is scoped out through that 7 minutes test? So in the world of face recognition, it seems to me that there's something that connects to some body of theory. In the world of language, and if you look at the tests that are used by Fedorenko and her colleagues, you realize that they don't connect to anything. It's just a collection of sentences. And the question is, how do such things here? You can see some examples of this. Okay, once again, it's some text. I hesitantly skied. It's not ski. I hesitantly skied down the steep trail, and so on and so forth. I don't quite know why this particular text is used and not something else. And the only explanation is perhaps it doesn't matter. But at least if we look back to the scientific literature, we know that it does matter. This is just one example. I'm using this example because it's close to my heart, because I've been kind of invested in this type of business. But it's really not the only example. And you want to see how this type of result that says there's a specific syntactic component that systematically activates the same area that you see disrupted subsequent to focal brain damage. How do this kind of result connect to the kind of generic tests that are being produced? So I usually see that there's something quite localized about this type of results and much less localized about these generic tests. And to demonstrate this point, yesterday I showed you a test, some paper by Mitch Berger and Eddie Chan from 2022, which showed how a disruption of Broca's aphasia outside of Broca's area, and something a patient with Broca's area lesion who has no functional deficit that resembles Broca's aphasia. So what I did, since I personally am interested in the receptive side, comprehension, I went and noticed what tests they used, and you may remember that I told you that part of the problem is that they use as their linguistic consultant a guy named Stephen Wilson. There's nothing wrong about him, but it helps knowing that he's the one who produces the language test, helps you see what's being tested. And I just want you to see what's being tested. So this is the language part. It's not that clear, but it's, are you a man? Are you a woman? Do you cut the grass with an axe? Are you about to, if you're about to leave, have you left yet? Are witnesses questioned by police? These are things that are usually classified as knowledge of the world or something like this. There's nothing particularly linguistic about this, and nevertheless, this is their sentence comprehension test that is used by this group. And after you give me this kind of thing, you cannot conclude that the pattern that you get is Broca's aphasia or some other aphasia. It's just some kind of rather arbitrary collection of sentences that have nothing special about them. So the only punchline here, I'm not even trying to be critical, at least let's be a little bit more informed in selecting the tests, that's all. I don't know if it's going to be useful. And remember, maybe whoever says that it doesn't matter what you probe, you will always get the same result, maybe they're right, I don't know. But you want to reach this conclusion after having failed. And at my age, failure is the name of the game. So not at your age. So at least we're trying that. So let me tell you the kinds of things that bye-bye. Let me tell you the kinds of things that we've been constructing. And the test that we've constructed consists of 3 parts. And to the extent that there's any contribution is first of all to look at all these things together, motivate them by alluding to results from both neuropsychology and psycholinguistics or neurolinguistics in the healthy brain. So it's like empirically driven. Plus, we set up this app, this iPad app. It was a very painful process, but somehow helped for this. It's actually an app that was initially designed for diagnosis and therapy of patients with stroke. And we're using it now in Charlotte Center Hospital. In fact, Muhammad here is working on it right now. And we adapted it with a postdoc of mine who used to be here by the name of Andreas Haida. We adopted it for the operating room. We made all kinds of modifications, and I think it solves problems that the neurosurgeons face when they are at the operating room, which are independent of these specific tests. And let me tell you a little bit about it. So, in the spirit of life at large, these things consist of like words, except here this is not picture naming, but rather picture identification. So instead of you having to say this is a ship, this is something else, what you do is you see 4 images and you see a word and you also hear that word and you're supposed to press the button that's right, okay? So this is a lion, you hear the iPad saying lion and then you're supposed to press it. So this is words. These words are divided into nouns that are simpler and nouns that are more complex on some measure of complexity, and likewise there are verbs that are simpler or more complex on some measure of complexity that we can justify. We then have a syntax test, and the syntax test is derived directly from what you've seen. Namely, we have syntactic tests of 2 types of things, one that's called questions and one that's called requests. The question are simple and complex in the sense that they are distinguished by this displacement rule that I showed you yesterday, which is exactly the one on which aphasic patients fail and which activate these relevant areas. So we have a contrast between subject question and subject questions and object questions. I'll show you this in a minute. And we also have tests of what's called relative clauses that can be simple and more complex, in that there are subject relative clauses and object relative clauses. I'll show you that in a second. We then have a semantics test that also has like a simple and complex version of it, and it has to do with negation, and it's also motivated in ways that maybe I'll show you in a second. So we put it on this kind of app, and what's coming up next? And there's several things about this app. First of all, it's the idea behind it was to devise something that you could not think about anything simpler. Very, very simple. Nothing much on the screen. And the reason is that for the most part, the patients who operated have never seen an iPad in their lives. We did it for stroke victims. And stroke victims, especially stroke victims, are usually older people. In Jerusalem, if they come from, let's say, the Orthodox community, they definitely have never seen, and the super Orthodox community, they've never seen an iPad. So my memory is from like an 85-year-old rabbi who I gave this iPad to, And I said, you need to push. And he pushed it so hard that he almost broke it. Like really, he's never seen such a thing in his life. We have to adopt it to just any population imaginable. If this ever succeeds, maybe it will be shipped to the jungle, somewhere where people do get stroke, even though they live in places where no treatment is offered. But at least maybe someday we will get some cheap ways to deliver at least diagnostic services to such places, let alone therapy. So, you want to adopt this kind of thing such that anyone can use it. So it has to be really, really simple and easy to operate. So the basic idea is to do something that's really, really simple and easy to operate. In addition, the question always is in the operating room, and later you will see pictures, you will see movies and pictures. The way the world is divided, maybe I should show a movie first, so maybe that's a better idea. So if you look here, let me show you this movie. This is how it works. Here you can see a student is holding this iPad. The surgeon, who I think is Mario, is standing here, and she is ready to stimulate the patient's brain. She is supposed to be coordinated with the student there. And when she's going to say now, the student will push a button. The student will push this button and operate the app. The sentence will play, will be shown, and then a picture will be shown, and the patient's job is to push the right character. This one happens to be a question, like which girl is the boy, is the man, oh, it's the wrong one, because this is photographic, and here I wrote down a Pune, okay? But never mind. But the thing I want to point out is that the universe here is divided in two. There's the part that the surgeon is seeing, which is the half of the patient's head that's a sterile field, and there's a clear sheet that's dividing that half, which is where the surgeons and the whole surgical staff is, and the patient's face that you could see from the other side. The surgeon cannot see the patient's face. And moreover, the surgeon cannot always know what the performance of the patient was. So the surgeon is completely dependent on the report that he or she will get from the student or whoever operates it here. And one thing we thought about is to take the opportunity and have the performance of the patient completely transparent to the surgeon. Actually, there are many things you can do. For instance, if you're using an iPad, you might as well use the camera of this iPad to show the surgeon the patient's face. Okay, so one thing I was thinking about, but we never got to do it, is to have some Bluetooth connection between the iPad and some monitor that's going to be in addition to all the stuff that these guys have, and this way they can see the patient's face all the time on a monitor, not on this screen. But why not do this? So there are all kinds of things that such a device can do, independent of the fanciness of the linguistic test. There are all kinds of things that such a device can do in terms of improving the communication between the testing staff and the surgical staff. Okay, the testing staff are very well-trained people. These are medical students that have gone through the training of these guys, and they're tough. Okay, they really are. They're the ones we all depend on for this type of stuff. And so it's important to realize that the world is divided in two, and there are advantages that can be obtained through this type of thing. I'll show this to you in a couple of minutes. Here is what you get. So after you start testing, you get a screen in which there's room for the patient's response. The patient's response will fill each of these little squares with either green or red color, which will indicate whether the patient performed correctly or incorrectly. So, maybe we haven't designed it perfectly, then it will keep building as the session progresses. And this is a way for the surgeon to get a performance at a glance. I don't think it's working properly right now, but the idea is to do it in a way that the surgeon can get at a glance impression of how the patient is doing on these tests. Maybe, I'm not sure we're doing it right, but that's at least the idea. The sentences that we use, again, divide into simple and complex ones. So here the simple ones are those that have a short green line or arrow, and the complex ones are those that have a longer red line, and the basic idea is this is a relative clause, so this is like the woman who the girl is pushing is blonde, as opposed, no, this one the opposite. The woman who is pushing the girl is blonde, and here the woman who the girl is pushing is blonde, okay? So there's a contrast in complexity between these on exactly the dimension that we know from healthy people is activating Broca's region. And also we know from stroke victims is disrupted, the contrast between these two sentences. Likewise, there's a possibility in German, which exists also in Japanese, which I mentioned yesterday. You can say something like, the table supports the chair. Here you can say the chair supports the table, but it means that the chair the table supports. Okay? So there's a variability here in complexity, and here you can see the same thing with questions. Which man is pushing the girl? Which girl is the man pushing? And so on and so forth. So at least we have some kind of a theory-driven, and two, empirically driven tests of sentential syntax that we can try to test. So this is the syntactic test that we use, and now we can get to see how it works. So what you could see is that Marion was saying jetzt, which means now in German, and then the person there was pushing the button, and you could hear somebody, Andreas actually, uttering the sentence, and it also showed. Those of you with a sharp ear may have noticed that the intonation is a little funny, and the reason it's funny is because we wanted to make sure that the patient is paying attention to the specific inflection that distinguishes the different cases, the different grammatical functions. So we kind of did it in an emphatic way to make sure that this is where the patient attends. So these are our syntactic tests. You can see.
Yes.
You could see that she was stimulating as she said yes. I'll show you one additional example.
Der Papierkorb enthält den Karton.
So here you could see the timing.
Der Bauarbeiter schubst die Frau.
Okay, so you could this is just focusing on the tissue itself, and you can see how the timing works here. I think I'm going to skip the next example, and I just want to show you the protocol of how this test is going. And this is where problems get even worse. So the idea is to get the patient to be tested pre-operatively on all the tests, and then to get the patient tested intraoperatively several times over. We need a baseline. If the patient's performance, as you will see on our tests, if the patient's performance is not good before the operation, you can guarantee that during the operation the performance is going to be even worse. So one thing that we did not get, and I mentioned it yesterday, I think, from the fancy schemas, from the papers that show you how words are blocked by this, by stimulating this region or that region, we don't know anything about the performance of any of these patients pre-operatively. So what's the point? You need a baseline. Without baseline, you have no information. It's extremely important. So here, at least given that these are tumors, we get baseline information by testing the patient the day before. It's extremely important to see how this works. It's also important to get the patient trained on the app. So when the patient is at the OR, they've already seen the app, and they've interacted with the app, and they've interacted with the app by sitting down and being as relaxed as you can be a day before your brain is going to be operated on. Okay, but at least it's a quiet room, and you know, people are friendly, and they can explain this thing to you, and you can do it over and over again until you get adjusted. But if you failed pre-operatively, the chances are not this. You know, the picture is not good. We must test it. Then what we do, once the patient is awakened, we retest the patient with the same stimuli once again, without stimulation, because the conditions in the operating room are different from the conditions that they had the day before. They're sitting in a quiet room. Now it's a very noisy room. Usually I count the number of people in the room. There are about 10 people in the room other than the patient. It's a big production, you know, and these guys are like big commanders of a huge staff. These are very well-trained staff, and everybody knows what they're doing, but there are many people in the room, there are machines in the room, it's noisy, there's an anesthesiologist and an assistant anesthesiologist, and an EMG specialist, and this nurse and that nurse, and people who keep bringing the nurses things, and it's like a big to-do. And my problem always is to find a place where I can stand without standing in anyone's way. At least I'm not disrupting the operation. I'm not helpful, but at least I'm not disrupting. So the thing is, yeah.
What about language processing?
I don't understand the question.
You're testing language comprehension.
Yes.
What about language processing?
What do you mean by language processing?
If the patient needs to say something, or you need to give
production.
Yes,
language production.
Yeah.
In this test, we don't test language production, even though it's quite possible. We don't test it. Actually, Naama doing it in Naama Friedman doing it in Ichigo, she only tests language production. In this one, what the goal so far, at least, has been to demonstrate the feasibility of these tests. The reason why we haven't tested language production is because it's very difficult to record it formally. So here, the patient pushes something, that's it. If we start, we thought about it, obviously. So what you can do is you can just record the patient. This works as a tape recorder as well. But what do I do? How do I evaluate the patient's errors during the operation? Remember, they need to use it. So the idea is that we have enough of language production just by virtue of their naming test. Yeah. It gives you a clue. It doesn't give you a clue at the sentence level, which is what you're interested in. It tells you nothing about sentence level errors. In this respect, your question is well taken. You do have a clue about their speech abilities because of the test that they use. This is a ship, this is a boat, this is something else, and it's quite extended what they do. But you don't get the test of production at the sentence level. This is not something that we do. At one point, and I think I brought one movie like this where I tested repetition, at least that, and you will see how the patient is unsuccessful. This is the patient whose performance was really bad to begin with. Okay. So your point is well taken in the sense that we do not test sentence production. We do not test sentence production. It's an important component, but that doesn't mean that you can't do this. Okay, so I'm not saying this is the ultimate test. Again, our goal was to demonstrate so far to show the feasibility of this kind of thing.
Okay, but I'm not asking about sentence level. I'm asking about discourse functions.
Thank you very much.
Yeah.
next year. It's too much. The limitations here are huge. First of all, you might want to ask about discourse functions, you have to be very specific about it. And once you start being very specific, I will ask you about the evidence that would have led you to choose this discourse function and not that. So you're going to have to go and show me that there's some literature from either neuropsychology, from deficits on the one hand, or from functional MRI, something that can be usable. I kind of know the literature. I'm not aware of anything that is usable. Many people tell you that they detected discourse deficits here and there. First of all, not on the left hemisphere. That's the first thing. And secondly, usually it's insufficiently informed linguistically for me to do anything with it. It's like impressionistic stuff. And the same is true for the imaging literature. In imaging, it's with fMRI, it's extremely difficult to do an experiment with discourse processing. I haven't seen anything to convince me that there's anything to it. So people will tell you that they did, but I would be quite skeptical, and if you want, I can show you why, but not right now. So this is a little bit overly ambitious, at least at this point. I wanted to stick to smaller things. Okay? So at the sentence level, we haven't, this particular project hasn't incorporated production, And so let me go back to the protocol. It's kind of important. So we test these patients twice with no stimulation before the surgery. Once a day before and once during the operation, but without stimulation. So we test them intraoperatively try to do it prior to resection, and then after resection we do it with syntax, we do it with semantics and everything, and then hopefully we come to their bedside 3 hours later and test them after the operation. And if everything works well, they're doing okay. It's not always the case. One of the first, patient 0, was somebody I will never forget ever in my life. I've seen many patients, but not neurosurgical patients. She was so sharp before the operation. She was rather sharp during the operation. And then we visited her like a couple of hours after the operation, and she did nothing. There was like zero comprehension, zero production, nothing. Virtually nothing. I think it persisted for like 2 or 3 days.
Could be that she's traumatized. It could be that she's traumatized.
Could be
that
she's traumatized. Yeah. Ask them.
Well, of course it can be, but in this case, and we got other patients like that, it's not just a trauma, it's not a theater. It's really temporary deficit we just caused by the operation, by the electrostimulation. We're causing edema, causing stress, so it's really not working. It has to recover.
As far as I remember, she went back to work after about a month. I don't know. Do you know what her whereabouts?
She's living quite far away from us, so.
But she's still alive.
Yeah, she had a control. A couple of we missed her. She had a control. The control was so well that they didn't even present her to us. It was a mistake. Yeah, but patients who have a complete normal setup just pass through and get a letter. Everything's fine. Come back in 4 months.
This is quite amazing, But I remember you were in complete panic. I'll never forget this. Remember, I started asking her to sing and do all kinds of stuff. Yeah. So things are quite surprising sometimes in ways that you cannot predict and you'll never understand. But that's just an anecdote. I mean, you have to do this repeated testing all over, unless otherwise you have no baseline and you have no conclusion. You want to see what happened. First of all, what the initial state was, and then what actually happened. So this is what we do. I want to tell you what the semantic tests that we use are for and why. So it's a very long story. I'm like taking a whole. I'm telling you, I'm taking 5 minutes for a whole semester's work. Maybe we should stop in about 5 minutes. So I'm telling you, like a whole semester. Actually, you know what? I think we should actually be fair to you because you've been sitting for an hour and a half. We should stop now, and I'll just begin with this tomorrow. Okay, good, much better. All right, see you tomorrow. Wait, no, don't go away. I need to get your names. Please write your names before you go away. You don't write your name, you don't take your credit. זה, קודם כל אתה צריך להגיד לי למה אתה רוצה לעשות את זה. אתה צריך להגיד לי למה. מה בדיוק בדיסקורס אתה רוצה לבדוק? מה?
אני שואל הפוך, מה יעזור לי במשפט
מה יעזור לך למה?